And Dennis had missed it. He'd been telling us Dennis that there was something growing in his mouth for ages, and he lived 3 days after. And she had children to raise. I found my husband dead about 10 years ago. He was dead in bed, cold and gray as a piece of concrete, and with livor mortis, so blood had settled to the bottom half of his body. He was very vibrant and athletic and always on the go, and turned my life upside down, and I didn't handle it very well. I'm not sure, she might have done better, but we both say there's no such thing as closure. So there's acceptance, but we think that closure is focus. And today is the anniversary of our late husband's death. So. Okay. Communication in terminal illness. This is very interesting to me. In closed awareness, the client is not made aware that their death is going to be very soon by the physician or family choice. Now, maybe the physician thinks the client doesn't want to know. Maybe the family thinks they don't want to know, and they decide together unless the client brings it up and asks specifically. And even then, sometimes they hem-haw around and say, well, nobody ever really knows these things. We're doing the best we can. Mutual pretense is everybody, including the client, knows the client is dying, but nobody talks about it. You all act like everything's fine. So they tell jokes, they watch funny movies when they sit in the hospital, they scroll on their phones and, act cheery and happy, and it really burdens the client because they feel they have to keep the secret. They have to play the game because their family wants it this way. So, and the client really has no one to talk to except usually the nursing staff. And the nursing staff, probably aren't going to bring it up unless the client does. But they can't talk to their loved ones because their loved ones are making it very clear they don't want to talk about it, And then open awareness. This is the best, of course. The client, the family, and healthcare workers are all aware of impending death, and they communicate openly about it, even though it's painful and difficult. It's awkward for awkward people like me. It's painful for them and difficult, but in the long run, it's the best way to go. So those 3 types of communication that you most often see. Hospice nurses get a lot of training and work through a lot of these things. They learn because their clients have a little time usually before they're going to pass, so they can get to know one another and do these things the right way, and even teach the family as much as possible, but it's really better to get it out in the open. Okay, so nursing care. To really be beneficial to someone who is terminally ill, you need, this is true, I guess, whether they're terminally ill or not, you need to be authentically present, emotionally available. So don't rush in and out of the room. Don't walk straight to the IV pole or pick up their IV line to give them meds, and do things with equipment without ever making eye contact or speaking. Sometimes nurses do that because they don't want to get engaged in a long conversation, or they don't want to get engaged with an awkward conversation. That's not really nursing. A robot can do that, or maybe a trained chimp, I'm not sure. So you need to be emotionally available for your clients. You need to have compassion with what they're going through and have some sensitivity. When you're empathic, it's not the same as sympathy, but it's not too far away. Empathy, you identify with the client to agree. You recognize that they're going through a lot, that there's that psychological pain of impending death. There may be physical pain too, depending on what the diagnosis. Very often there is. But caring nurses are described as warm and empathetic, compassionate and consoling. So, letting them know that you do care about what they're going through. You can't stop the fact that they're dying, but you do care about what's happening to them. And we also have the family as our clients because they are in need of care as well. And sometimes they want to talk. Maybe the client himself has slipped into a coma, or they're well medicated at this point and in deep sleep. Those family members may want to talk at that point. They may want to talk about what's special about their loved one. Some of the people that I have most enjoyed taking care of at the end of their lifespan were veterans, because they could tell some stories, maybe that they waited to the end of their life. Maybe it took them this long to be able to talk about their military experience. Most of our World War II veterans are gone now, but I guess I've had the honor of talking to quite a few of our World War II veterans in the last 30 years and at the ends of their lives, and let them know that we appreciated what they had done to keep our country independent and safe. You want to avoid trite reassurances. This was another reason I would run out of room. I wanted to say things like it's all going to get better, and I knew that wasn't true, and that was hollow and shallow and not helpful. But since I didn't really know quite what to say, those kind of things, you almost blurt them out. But try to plan before you even go in the room. Tell yourself, I'm not gonna do those things. I'm not gonna be dishonest. I'm just gonna do the best I can. And I think they know, even if you don't have a real smooth delivery, that you are concerned about what's happening and that you want the best possible death for them. So the family, a lot of times, I said the client will ask you, what do you think will happen with me? And the family will also ask you. And that's a little different because the client, the patient most often has a decreased level of consciousness toward the end. If it's like heart disease or respiratory disease, metastatic cancer, they're starting to drift off and not be as aware of their surroundings and things, but the family's sitting there watching, they will perhaps hear what we call a death rattle. The mucus gets kind of dry and thick in the throat sometimes, and it's hard to clean that out because it's deep, and they may hear something so if you prepare them, they may hear some rattling beforehand, and not to be alarmed by it, but it's not painful, and that might be better for them. They may see some modeling where the extremities get cool and they're not perfused well, and their skin becomes a little kind of spotted, almost purple and white. Of course, we talked about not taking anger personally and letting them reminisce and talk about funny stories, things that happened with their mate. The time they did this or did that and got lost and couldn't find their way out of a cave or something on some vacation. Different things they want to tell you, and you can laugh a little bit and sometimes cry. And that's okay too. So, common things the nurses deal with, I guess pain is a big one, keeping them as physically comfortable as possible. That's really one of our main responsibilities with someone who is dying. If there's no family or loved ones around, we do run into that too. There are people who have outlived nearly everyone they care about, and they are having maybe quite a bit of anxiety or loneliness, then you need to spend extra time with that person. And also, if they do have someone they would like to talk to, you getting a hold of them, finding, saying, just tell me, you know, who it is, and I'll give them a call. Maybe it's a neighbor, maybe it's someone from their church. Maybe they have someone from out of state that they kind of hated to ask to come. Oh, I didn't want to be a bother, but, you know, my nephew is in Little Rock. Well, let's get him on the phone, you know, let's get him on the phone. A lot of times the nephew says, I had no idea my Uncle Bob was in that bad of shape. I'll be right up there, you know. So sometimes they're just such kind people, I guess. They just don't want to be a bother, and they really aren't being bothered. Sometimes they're afraid of dying. They're afraid of the experience. They're afraid of what comes next, and you may need to medicate them for anxiety, or you may just need to sit with them for a while and let them know that you're going to be fast to answer their lives, and that they're not going to be. A lot of people are afraid to die by themselves. They want someone in the room, and they want to be reassured that someone will be there, which, that is kind of hard to do if you're on a med-surg floor or a skilled nursing unit or something, where the nurse-patient ratio is high. It's not, an inpatient hospice it's not too hard to do, or intensive care unit, but, you know, you can say, we'll do our level best, and we're going to check on you so often that, you know, it's very unlikely that you will be by yourself. You know, you can't promise, but it's to say that almost never happens. We're going to have you right by the nurse's station, and we're going to be where we can see you. You want your client to see the acceptance. That's easy for some, and it's not going to happen for others. Some people are going to die angry or depressed and hopeless. Some people live their whole lives that way, and that's the way they want to die. Others, and it's just not possible for them to accept that they're dying. Sometimes that's people without any faith in an afterlife, and that's, which will lead to me, and everybody thinks differently. If I was an atheist and I believed there was nothing after death, that wouldn't be that scary, because let's just be afraid. You just go to sleep and don't wake up. On the other hand, if I was a Christian, thought I'd lived a terrible life and that I was going to hell, now I might be a little afraid of that. But, so, and then there's the agnostics. They just aren't sure what they think. Yeah, well, they start figuring it out toward the end. They go one way or the other. Okay, so outcomes. We hope our clients will be physically and psychologically comfortable at the time of their death. That's our goal. And we're going to do everything we can to make that happen. We want the client to achieve a dignified and peaceful death. You know, we don't want them to kick off the covers and be lying there with their genitalia exposed, with the door open, and mucus running out their nose when they die. And, you know, we don't want that to be the last sight one of their loved ones walks in and finds them dead. So you do your best to try to keep them looking presentable. Do oral care. Oral care is really important because a lot of times people are mouth breathing and they're not able to clear their secretions well, and their mouths get really nasty. And that bothers a lot of people. If you clean their dentures and use those scrub brushes in their mouth and get their mouth to feeling good, they feel much, much better. And that's such a little thing. And then you hope that they will maintain a sense of value and be able to acknowledge their impending death and say, well, I left the world maybe a little better than I came into it. And you could probably help people think of some good things that they have done. What's something in your life that you look back on and you're glad that you did it? It might be something as little as going out to the dog pound and adopting a dog. Or it might be that there was a neighbor kid that really didn't have enough to eat, and they used to take them over some leftovers, you know? It might be something from 20 or 30 years ago. They helped someone out, loaned somebody $20, and it took them 2 years to pay it back $1 every other week or something. But, you know, I believe everybody has done something good at some point in their life, and then you can expand on that and say, you know, a lot of people wouldn't have done that. That's a nice thing. You don't know what came from that. That person might have went on and done some good things for other people because you were a good role model for them. So I don't think any of us are all good. I don't really think any of us are 100% good or 100% bad. And I think we can help our clients find some goodness in themselves, even when they start thinking it's not good. Now, you don't have to go to this chapter really. I don't have test questions from this chapter, but I did put a couple of, at least one slide, because it's a chapter on caring, and it talks about that nurses must care for themselves in order to care for others. And I think that's true of all human beings. If we do not value ourselves a little bit and do a little bit to take care of ourselves, we're not in shape to take care of others. And honoring the connectedness of all leads to transpersonal care and healing. It's kind of some of that Zen-like thinking that, you know, if you kill a tree, you kill a part of me. That kind of thing. That if you try to take care of the universe, all the small parts of the universe, that that a little bit of healing takes place somehow, some way, somehow. Therapeutic use of self requires knowing yourself first. So, to be therapeutic to others, you have to kind of know your beliefs, and then that last sentence is very, very important. If you do not get to know the client, you cannot truly care for them. That's why I said I like the old soldiers so much, because if I could get them talking about their experiences in the military, then I could feel that I knew them. And you know, because I grew up in the country, I like little farmers and ranchers too, because they'll start talking to me about some particular, their favorite horse, or some bull that was so mean, and then I feel like we can connect, you know. A lady that's worried about who will take care of her dog when she's gone, I can relate to her, you know, that's something that I would worry about. So I try to find something we have in common, or at least something I can relate to. I try to get to know them well enough that I can relate to them and they can relate to me. When I walk in the room, they know a lot of times if they've been there a few days that I have a dog named Tater, if they're a dog lover, you know. So we can chat about our dogs, and I'm not just a robot, like I said. Okay, hospice and palliative care. They're two different things. Hospice has been around the longest, I think, and Medicare pays for hospice. In order to go into hospice, a doctor has to write a certification of sorts that says that their life expectancy is less than 6 months. Now, there are people who've been on hospice a couple of years, and sometimes they have to be released from hospice and go maybe to home health and sometimes go back to hospice. Another thing they have to agree to is that they're not going to do, maybe if this is a cancer person, I'm not going to do chemotherapy, I'm not going to do radiation, I'm ready to just let life happen and take its course. Let this process go on as it's going to go on without very aggressive interventions. and surgery, transfusions, and the hope is that they will be able to die at home and not go to the ER. When the family thinks that they're dying. I've seen that change a lot of times. So they panic. The patient is on hospice, and then the family gets scared. We're changing our minds, and they don't feel comfortable, and they call the ambulance and take the patient to the ER, and then the ER says, well, what are you doing here? You can't be on hospice and be getting, a bunch of CTs and possible surgery and all these things at the same time. They have to make their decisions which is going to be. They can't have it both ways. So they don't attempt to prolong life. You do hydration and food when they're hungry, water when they're thirsty, food when they're hungry. Pain management, symptom management is the focus, and psychological care. The difference then with palliative care is that someone on palliative care can also continue to get chemo or other mechanisms to prolong their life. And I'm not sure how that works out financially. I don't know who pays differently. Like, we have patients sometimes during our clinicals that they say they're here for comfort care. This is someone who's dying. I don't know if Medicare pays a lesser daily rate for that, or just how that works. But it is a medical, there are orders to say, take care of this person's comfort, give them a breathing treatment if they need a breathing treatment. If they're uncomfortable, feeling like they're choking, give them a breathing treatment. They can have oxygen if they ask for oxygen, and so on and so forth. Okay. We went through some of these things already, but it doesn't really hurt to do it again. So, caring, compassion, confidence, commitment, comfort, making sure that you turn that person often and try to keep them from being stiff and sore and uncomfortable in the bed, reposition them as often as they need to be, do meticulous mouth care. Makes a world of difference to how comfortable they are. Be quick to check on them with pain. Sometimes they have pain medication ordered around the clock, IV medication, not PRN, but routine, with medication for breakthrough. Sometimes they have the patches and then IV medications you can give for breakthrough. So there's variety, but the issue is to control pain. Help them acknowledge, what they're sad about, missing out on Christmas. My granddaughter's pregnant. I haven't seen my first great-grandchild, things like that. But you care about them, provide care as if they were going to live. They're not the last patient you go see necessarily just because they're on palliative care, or that they're not going to survive this hospitalization. You still take care of them in your mind, certainly, as if you do everyone else. Prioritization, honestly, if this person is having some, the respirations are declining, and someone else who is not dying, his respirations are declining, I'm going to go see the other patient first, because there may be some emergency response that, they may need aggressive treatment that would involve moving to ICU and putting them on a ventilator. Who knows? Maybe they've thrown a clot. There are a lot of different things that are going on. Post-op patient, maybe they're bleeding in the lung. But so just in terms of prioritization, we take the most critical situations first. But this person is not just automatically at the bottom of the totem. And then, as I said, preserve their dignity to the best of your ability. keep the environment as nice as you can, try to keep smells down, make, and, you know, you turn the lights down if they like to have them down, and often they do. Don't whisper. A lot of times family will whisper to you, and don't whisper back, because the client, hearing is the last thing to go, and I would not want to be dying and hear people whispering in the room around me, and I know they're talking about me, you know, and I would think that was rude. So, don't do it. And make sure the family knows that from all we know, hearing is the last sits together. They kind of close their eyes and don't really look around, might not be aware, may or may not be aware if you're holding their hand, but they very well may be hearing you. And you can sit and talk about good memories you have with them. And then the loneliness issue, not feelings of loneliness and isolation. Make sure you check on that client frequently. And try not to let them fight. Okay. Evaluation, did they die peacefully without pain present? You know, that's usually possible. If it was present, was it at a level that they're comfortable with, that they're satisfied with, you know, a 2 or a 3? You don't really want it much any more than that. Even if you think that shot of morphine might cause them to have respiratory arrest, and that person is not going to live much longer anyway. I'm not saying I believe in euthanasia or that you should go out there and kill off your patients, but don't be afraid to medicate them if they need it, even if you're worried that it might be, it might contribute, or it might speed things up. It might not be. I mean, what your purpose is to keep them comfortable. And if, you know, they're breathing 12, and the medication that's ordered is 2 milligrams of morphine, you know, I've never seen anyone die from 2 milligrams of morphine, unless they were dying anyway. I would not be afraid to do that. If you are, go talk to your charge nurse. I wouldn't tell anyone to do something they weren't comfortable with, but I don't want you to let your patient suffer because you're afraid to medicate. So if you're uncomfortable, talk to your charge nurse. You're always going to have one. And then try, as we said, was there anxiety relieved? Were loved ones present? Keep their dignity preserved, and let them know that they were worthy people and had value up to the end. So signs of impending death, things you might see in terminally ill clients. One of the things you see is that they stop moving around very much. There's minimal or no movement. Muscle tone is relaxed, more flaccid most often. A slowing of the circulation, which includes lowering of the blood pressure. That may be one of the signs that just slightly, very slightly lowering the blood pressure. Pulse can go up and down. It could jump up to 150 and go down to 50. You just don't know what the heart's going to do, or those electrical impulses. But eventually, as they get closer and closer to death, generally it starts drifting downward into the 60s, the 50s, the 40s. The respirations, they can become deeper and louder, or they can be more and more shallow. So can't really say what they might do, but generally they're irregular at the end is very close. They lose that regular respiratory rate that we expect to see in all of our clients. And then the last one there, maybe should be the first, is the lethargy, sleeping more and a decreased level of consciousness. So some more things. Let's see. Oh, impending death continues. So because of that loss of muscle tone, it's a little harder for them to speak. You might have to get right up to their face, very, very close, put your ear by their mouth, because they're so quiet when they speak. They might not swallow as often or well, they might choke, or they might lose their gag reflex. A lot of times the mouth just falls open, and sometimes they have loss of sphincter control. And I want to tell you that may or may not occur. I've seen it probably less often than I thought I would coming out of nursing school. I thought everybody peed or pooped themselves when they died. When, you know, I think I learned that in nursing school. I'd say it's less than 50. I think it has to be more with trauma, with people with sudden deaths, I think, than people who are gradually dying. Now, if they're already incontinent, obvious they might. The sphincter may just go. But usually a lot of people haven't been eating or drinking much of anything, and there's not much there's nothing in the rectum, there's very little in the bladder. Because patients worry about that. They'll ask. Sometimes they ask about that. I don't want to do that. Well, I don't want to poop myself. Well, let's go restart chemo and have some radiation. See if we can keep that from happening. No. But that's something people worry about, and I understand that because it's part of that dignity thing. So, and I just tell them, it doesn't happen as much as you think. With the slowing of the circulation, the skin starts to cool and be a lot colder in the extremities first, but they do lose, their temperature usually drops a little bit. We said an erratic and weaker pulse. I think we said erratic. Now weaker. With the slowing down of circulation, you're going to have a little weaker pulse. And we already said decreased blood pressure. And then the modeling and cyanosis of the extremities, the toes and feet and fingertips might get kind of purple. You might see that kind of spotted. I wish I had a good picture of modeling. I don't remember if there was one in the book. If you put someone on a really strong vasoconstrictive drug, you could, in the critical care unit or something, and it's a pretty high dose, you could see modeling cyanosis of extremities in people who maybe are very critically ill, but who recover. So it's just because they're of a lack of circulation. So that happens. So the respirations, we said maybe rapid or slow, usually irregular and shallow. But noisy breathing, the death rattle from mucus often, a lot of mouth breathing, dry mucous membrane, so you want to do oral care. And probably blurry vision and not really seeing. They may hear by the voice who's present in the room and know who's there, but be less likely to actually look at them and see and recognize them, although sometimes they can do that too. Decreased senses of smell and taste. Nothing's really tastes very good. Nothing smells good. Doesn't make them hungry. Lack of appetite usually. After the person passes, you must notify the primary care physician, whoever has hospitalized that patient, the hospitalist, your nursing supervisor, and then normally, if this is an anticipated death, you already have a listing of who the funeral home is. And of course, let the family know as soon as possible. You want the family to get there before the funeral home, because the funeral home doesn't usually like to wait very long, and they get kind of testy. If you call them at 1 in the morning and they have to sit around for 2 hours waiting for the family to come. So workouts, details. So do not remove any lines if there's a possibility of an autopsy. And generally, if there has been a surgery within a week, there's a good possibility of an autopsy. A lot of times the surgeon wants it just in part to cover themselves, to make sure that people know, that the family knows that there wasn't anything, and wasn't a sponge or an instrument left in the abdomen or something. Let's see, if somebody who's previously healthy and they're coming to the hospital just really, really sick, and before you get any results back, they're dead. A lot of times that happens in the ER. There may be an autopsy, so until you know from the physicians that there's not an autopsy, don't pull the IV out, don't remove the Foley catheter, if there's an NG tube, don't put that down, don't take that out, don't take an endotracheal tube out or a cervical drain, just leave everything in. And that's kind of hard. You have to explain to the family. If they're there at the time, they want you to remove those things immediately. They want to see their loved one the way they really will. But you have to wait until you know. You guys can read this part. Rigor mortis is the stiffening of the body that starts within about 4 hours, reaches the extremities last. Alga mortis is the dropping the body temperature. And livor mortis is that discoloration that I talked about. It's kind of a purplish because the blood settles in the dependent areas. So the heels, whichever way the arm is lying, the bottom half of the arm will turn purple. Sometimes the chin, even earlobes sometimes turn purple. And it's because the blood cells are breaking down and releasing hemoglobin into that surrounding tissue. Organ donation. I know I'm going to lose you, but we are required legally to cover organ donation. Usually house supervisors have had that training. If you haven't been trained, do not ask the family about organ donation. You need to find someone who's been through a training and is qualified to ask those questions. Generally, there's some ER staff or ICU nurses who've also been trained, as well as the house supervisor. And some tissue can be donated after death, like corneas, bones, skin. And don't just assume because they have cancer that they can't do donation. I know because my mom died in burn unit, that skin is vital. The skin is very, very important. So she died last spring and she had skin donations. And I thought to myself, I didn't ever think that skin would be that important, but it truly is. Address the cultural needs. If the person is close to death, if you'd like to talk to the family earlier. So the Muslims would like to have the body facing east toward Mecca if possible. Many Roman Catholics would like last rites. Native Americans often have a spiritual leader that they want to have come in, and they may want to dress the body themselves. And as might Mormons, anyone who wants to do that, let them do as much as they can for their deceased loved one. They're, an integral part of this. So, culture, religion, and past experiences affect anyone's concept of death, ours included. Some people may actually want to go home to heaven. They're ready, they're in a hurry. You're like, hold on. You're not that close yet. They talk about reuniting with their deceased loved ones. Some are angry and blame God for what's happened to them. Some of them consider a good death to be a reward and are looking forward to the next one. So everybody has different thoughts about dying. And that's okay. We're not all the same people. And we just want to honor their wishes. And that's our job, to the extent that we can. Questions?